regret going last because those were much better than mine, but I'll give it a shot. This is kind of a dense topic, so bear with me. My name is Bilal. I'm going to be talking about decision making and cognitive bias. So, just a brief overview. I'm going to talk about dual process theory, go over some cases, specific types of bias, and potential solutions. So, I think this is important because a lot of us kind of gravitate to resuscitations, critically ill patients, and doing procedures like intubations and chest tubes. But most of our jobs is not doing those things. Most of our job is speaking to patients with vague, undifferentiated complaints and trying to rapidly and accurately arrive at a management plan. And despite our best efforts, we make some mistakes, actually, probably a lot of mistakes according to the data. So, one study in 2023 found that errors were identified in up to 7% of all admissions, and 1% of these were considered serious or life threatening. It's thought that a lot of these errors are due to cognitive biases rather than knowledge deficits. Now, this is actually something that I think is pretty hard to prove when you the case to see exactly what caused the error. But given the amount of decisions that we make and the amount of potential biases that we have, I think it's safe to assume that some errors that we do are due to bias, so we should try to understand them and address them. So one of the main ways in which people say that we think is based on two systems or two types of thinking. Type 1 is our intuitive, automatic kind of gut instinct, or something that we may compare to clinical gestalt. It's just when you know something. Type 2 is more reflective, slow, and deliberate, and it involves a lot more focus and effort.
Hey, I've seen this one. This is a classic.
That's kind of what I think of for type 1. It's like when you're in CCT and you peer over the desk and you are made aware that there's a patient with a finger stick of 500 and he's has Kurzweil respirations, and you're like, okay, I know what's going on. Or when you see someone with back pain and they have a rash and a dermatomal distribution, the patterns kind of click in your head automatically without you having to think too much. Now, classically, it was taught that type 1 is worse than type 2 because type 1 is reliant on pattern error and it's going to lead you to be susceptible to a lot of bias. Now, that is probably true in some situations, but when we're faced with a critically ill patient who's actively dying in front of us, type 1 is probably going to be very helpful in that situation. Type 2 can be better when something necessarily doesn't fit and you have to be more slow and deliberate about it, but you have to factor in the fact that it's very taxing on your working memory and can be tired in a situation where you're already prone to so many other distractions. Now, case number 1, we have a 69-year-old, this is a real case that I had. We have a 69-year-old male with a history of diabetes, hypertension, stroke, and diabetic retinopathy coming in to an outside hospital in not Kings County for right ankle pain. They document that he had no fall or trauma and also state that he's having blurring of vision plus headache. Patient has proliferative diabetic eye disease followed by eye physician, no changes. They document a normal physical exam except for tenderness to his right ankle. In the MDM section, they say his dizziness is likely due to autonomic dysfunction and he has no focal cerebellar signs. And they say he has worsening right ankle pain without any trauma. This patient ended up having a CT head and was discharged home. One thing I would like to point out is that that dizziness was mentioned in the triage note, but they never discussed it in the HPI, and they never really discussed a differential besides saying it's autonomic dysfunction and there's no cerebellar signs. He returned to that hospital 7 days later. At this time, they say his history again, and they say he's complaining of dizziness, epigastric burning pain, and burning pain around his left eye, which goes towards the left side of his head. He denies any vision changes or photophobia. So right in the HPI, they say an ultrasound was done concerning for vitreal hemorrhage, and these images are in the media. They document a normal physical exam, but there was no neurologic exam documented. In the MDM, they say they're going to refer him for ophthalmology consultation, and they document that he's not in DKA. So despite the fact that dizziness was mentioned in triage and the HPI, there was no neuro exam performed, and there was nothing mentioned in the medical decision-making portion. When he was transferred to Kings County, the ophthalmology resident was basically waiting in the ambulance bay for him, and he started examining him. And he said that there's no vitreous hemorrhage, there's no retinal detachment, and he can just follow up in clinic. So the patient was interviewed again, obviously this time with the benefit of this basically being a third visit and knowing that there's nothing wrong with his eyes. The daughter's at the bedside who says some of the same stuff again, but she also says his dizziness is getting really bad. He can't walk and he feels like he's stumbling when he's walking. On exam, he had dysmetria to finger to nose, a markedly unsteady gait. Neurology was consulted and the patient was admitted to the stroke service. MRI confirmed a posterior stroke. A few days later, he aspirated, had a cardiac arrest. They achieved ROSC after 5 minutes, and he was sent to the ICU where he's being treated for aspiration pneumonia. So I think there's probably a couple of things, we can point out in the first two visits. One being, if they were concerned about stroke, they shouldn't have just done a CT head because with dizziness, they would have been concerned about a posterior stroke. And this isn't to like badger on what someone else did, it's just to kind of point it out. And in the second situation, it seems like they fixated on his eye complaint to the point where they did an ultrasound and were really convinced that they saw something that wasn't there and stopped investigating further. I think this shows something called anchoring bias, which is the tendency to focus too heavily on the first piece of information. Now, this isn't like the first thing the patient says to you. This may be the first piece of information that you consider to be important in the history or physical. Every other piece of information after that is going to be viewed through that initial lens of the impression you had of the patient, and it's pretty difficult to break away from that impression. So some potential solutions to this are things that I think we do pretty well already, actually. So enlisting the perspective of your colleagues and having regular meetings to discuss patient plans. This is basically rounds at the end of shift. And a good part of rounds is questioning other people's clinical plans in a respectful manner, just like you would question any other piece of information, because it may actually lead you and them to recognize some bias that they may have had in the case. Frequently run your list and reassess your patients. This can kind of help you break away from that initial mental snapshot or impression that you had of them. This one may seem counterintuitive, but resist the urge to make decisions in a hurry. I think we're all always rushing, but realistically, you don't only have 30 seconds to make a decision. You probably have like 5 to 7 minutes, which is, as we all know, a really long time in emergency medicine. Have a set of obligatory triggers in your EMR, like sepsis triggers and suicide triggers, things that will like make you address the patient or think of a certain diagnosis that you may not have thought of. And the last one is always attempt to disconfirm whatever feeling that you may have about the patient or whatever you think the diagnosis is. Just ask yourself once, could this be anything else? I think another thing this case showed was something called premature closure. This is basically the tendency to stop the decision-making process and accepting a conclusion before you have fully verified it. In this case, it was kind of assumed that it was definitely an eye problem and not anything else, despite the fact that he had other problems and the patient was sent over for transfer, despite the fact that other things could have been done prior to that. A good way to address this is cognitive forcing strategies. One of them is basically doing a secondary search once you have a positive finding. So an example is you have a chest x-ray with a rib fracture. Look for a second fracture because those are commonly missed. If you have a psych patient with altered mental status, don't assume that it's a decompensated psychiatric disease, and just be on the lookout for if you need to do a medical workup, because these patients are also often have misses in bad cases. Another one that I like is doing it in a specific situation. So if you have a patient with ischemic sounding chest pain and you're getting ready to admit them, just ask yourself, could this be an aortic dissection? These are difficult diagnoses and they are often missed. Just because you ask yourself it doesn't mean you need to do the CT chest and abdomen, but if you don't think about it, you are definitely going to miss it. If you have a patient who at triage it's written down renal colic and a UA comes back before you see the patient that shows red blood cells, just think for a moment, could this be a triple A? It's probably not going to be, but if you don't think about it, you will miss it. And another thing is using a problem list of all the symptoms that a patient has. I think a lot of the times we feel like we need to kind of put everything together under one label, but you really don't need to do that. And having everything written down on a piece of paper can actually help you realize that you're missing something. The last one would be peer review and M&M. There's a good model for this online, like the Ottawa M&M model on how to do this in like a constructive, non-judgmental way, which I think we do a pretty good job of. It helps us identify possible errors and address them for ourselves, not for purpose of saying, oh, you had a bad case. So case number 2 is a malpractice case. We have a 48-year-old man who presented to an urgent care with fever, malaise, fatigue, and dizziness. He was seen by a PA. It was 2017 during a surge in influenza cases. The PA ordered a rapid influenza test, which came back negative. She felt his symptoms to be consistent with the flu, and given the elevated community prevalence, decided it was a false negative test. She diagnosed him with influenza and prescribed Tamiflu. The entire visit lasted about 20 minutes. After discharge, the patient's wife alleged that he was unable to walk back to the car, and a tech from the clinic used a gait belt to lift him into the wheelchair. He was helped into his car by a tech and his wife, and they drove home. So over the next few days, he developed a worsening fever, confusion, and was not responding appropriately. His wife called 911, who took him to a nearby emergency department. This is basically the summary of what happened in the ER and the hospital. So he came in with altered mental status and a fever. They intubated him to accommodate the workup and for airway protection. A CT head showed several small infarcts, and a LP showed 3,000 white blood cells and a group positive for strep pneumo. MRI confirmed several strokes in the bilateral frontal lobes. These things in conjunction made them worried about endocarditis. He was treated for endocarditis and meningitis, eventually downgraded to the medical floor and sent to a rehab unit with significant disability. So the wife and the patient sought out a malpractice attorney, and this is the expert case review. We don't have to read the whole thing, but essentially they get an expert who says his qualifications in the field, and he goes on to say that because of the patient's symptoms of fever, confusion, dizziness, and weakness, and cognitive changes, the PA should have been alerted to seek a higher level of care and to, order some workup to assess for sepsis or meningitis. And because this was not done, the patient suffered significant disability. So the urgent care and the PA were sued separately. The urgent care settled out of court. The PA's malpractice attorney, her defense attorney from her insurance, tried to settle for $250,000, and the patient refused that. This was the eventual verdict from the jury for over $20 million. I think a lot of this can be just for shock value. They're not actually going to get 20 million, but just something that I thought was interesting. I think, again, you can recognize a couple of pitfalls in the case. One of them was definitely treating the patient with the flu despite a negative test. And I think a lot of this stems from the fact that we want to give patients a diagnosis, and patients also want a diagnosis. It makes them feel a lot better. But we have to realize that it's not our job to give anyone a diagnosis. You have to resuscitate the unstable and identify dangerous conditions. After that is symptom control and an appropriate disposition for the patient. I think in this case, that may have played a role in this, just attaching a label onto it because she felt more comfortable with that. The other thing was, if someone's not walking, you probably shouldn't discharge them home. Now, unfortunately, we really don't know if the provider was aware that the patient was not walking. It could have been that this was all done at the tech level, like they just escorted the patient out and she was in another room charting. But probably a good reminder that we should just make sure that people can walk, takes a few seconds, it doesn't cost anything. And the other thing in terms of bias that's demonstrated was availability bias. This is basically when we overestimate the likelihood of a diagnosis based on similar examples readily available in our memory. This can be because of high disease prevalence, or it can be because we had a recent bad outcome, like a missed appendicitis, or because we were recently sued about something. It's just going to be heavier in our mind. So some solutions to this are, again, considering alternatives, just stopping and asking yourself, what else could this be? Physically writing out your differential. Well, it seems like it's silly and will take a few seconds to do. I think it can definitely help, especially when you're first starting out, because when you write it out, you're going to realize you may be missing a can't miss diagnosis. Limit your reliance on memory whenever possible and use cognitive tools, use MD Calc, and have like apps that can just have information for you so you don't feel like you need to memorize it. And just consciously pause and reflect, especially in the middle of flu and like norovirus season, because a lot of the times appendicitis is going to be sent out you with a label of gastroenteritis, and meningitis is going to be sent out as the flu or viral syndrome. We just be careful when you have a high community prevalence of something. So the other thing that was mentioned in the case was that one, the visit lasted 20 minutes, and this was the last patient seen of the day. So the patient felt like they were rushed out of the urgent care. I think this demonstrates something called decision-making fatigue, which is our deteriorating ability to make quality decisions after a long or intense period of doing so. ER doctors are incredibly susceptible to this because we have what's called a very high decision density. That's making a lot of decisions in a very short amount of time that have a profound impact on people's lives. And this is in conjunction with all the other things going on. On average, you're going to be interrupted every 5 to 6 minutes with things that are not related to the patient you're currently talking about. And there's going to be a lot of other systemic things you have to address which contribute to this fatigue. Some solutions of this are be aware of hunger and thirst and tiredness. Try to sleep well before shift. Try to have some snacks, maybe a juice or something to keep your blood glucose up throughout the shift. Be more deliberate with this center pizza. Be more deliberate with decisions, especially after something that was emotionally taxing or at the end of shift. Be very careful disponing patients at the very end of your shift, especially if you did not spend much time with them. Prioritize harder decisions and delegate simpler tasks to other staff members whenever possible. Again, algorithms and checklists to limit working memory. And some things at a systemic level are, I think, something that we have, which is a good sign out culture where you don't feel bad about signing out a patient because you haven't spent too much time with them. Limit the number of shifts in the high acuity area, which is also, I think, something that's done appropriately. Most people get like 3 or 4 CCT a month. And overlapping shift start time. So at the end of your shift, there is another doctor who's kind of taking over so you can wind down and just dispo everyone else appropriately. So in summary, I think when looking at these two types of ways to make decisions, one is definitely not better than the other, but expert decision makers probably blend these two, starting off with type 1, and then if something doesn't fit, switching to the slower, more analytical thought. Something that I think really helps a lot with this is going back and reviewing your cases and attempting to identify your own bias. Sometimes you look back at a case of somebody that you admitted and you'll be really surprised of the outcome. So I think this, reflecting on that, can help us learn a lot and actually make us better thinkers when we approach the next patient. And just continue to try and learn about and understand bias to try and address it for yourself in the future. These are my references. I don't have a sappy part, but I want to say thank you to all the Dr. Willis, all the APDs, Dr. Gernsheimer, my co-residents, my parents, God first and foremost. Yeah, any questions?